Okay, so good morning, hello everyone. Good morning and good afternoon to Korean participants. My name is Youngsung Lee, professor of health policy and management in Chungbuk National University in South Korea, and also I am a director of the board committee of Korean Society of Medical Informatics. I can see some familiar faces, including Dr. Ujin and some other Korean fellows, and the new one mostly from the Pakistan. This emergency seminar, I call emergency seminar, has been held by the request from Pakistan in the current situation of the COVID-19 world crisis. So this meeting was made possible thanks to the participants of specialists from many areas. So these specialists include IT experts and the clinician groups and the national institutes such as KISTI and the Indian side, any Pakistan side institution. So from the beginning, I was interested in defining the situation of the society or a national crisis through important meetings with experts from many areas and look for the best solutions. I'm expecting that this meeting will be productive to the current situation and the COVID-19 crisis. I express my gratitude and support to two organizations, the Korean KISTI and the Pakistan organizations. Before starting, we just introduce in each country. So maybe first speaker, Dr. Haewon Jeong. Just raise your hand on the front of my camera like this. Professor Haewon Jeong. Haewon, where are you? Okay, so I changed the screen menu, all the side. Okay, Haewon Jeong, yes, from the MedRIC from South Korea, and also Dong-Hyun Kim. Okay, and all these two special presenter on this session. So just a check on Pakistan side. So who is organized the Pakistan side? Just say hello and just a brief comment on this.
Hello everyone. From ICCBS Karachi.
Yes. Okay. Okay. Thank you. We can hear you and we can see you very well. So, and now I introduce two speakers who will host this meeting today. First, Professor Dong-Hyun Kim. He is currently a CEO of Korean Society of Medical Epidemiology, and also he is a member of the committee helping the government to fight the COVID-19 crisis. So, would you start from Dong-Hyun Kim?
Thank you for having me here. My name is Dong-Hyun Kim. I'm current president of Korean Society of Epidemiology.
Okay, would you share your slide or?
Actually, I sent my slide to your team member.
Okay, we can share your slide. Okay.
Yeah, okay. Could you?
Just a moment, please. 최영 선생이 좀 슬라이드를 올려줘야 될 것 같은데 공유해 주시고. Professor Hong Hae-yeon, so would you share this slide? His slide?
유영성 교수님, 누가 먼저 하시겠습니까? 제가 김 교수님 것은 가지고 있거든요.
Yeah. Dong-Hyun Kim Dong-Hyun, yes, he is going to present first. Okay. Okay, Dong-Hyun. Okay, can start.
Okay.
See if you can come and help me.
I'm going to talk about current statistics of COVID-19 as a public health crisis, and about the response strategy in Korea.
You're mute.
Yes. Here I cannot click the slide page. Yeah. Okay. This slide shows the content of my talk, epidemiology characteristics and outbreak as public health crisis, and the response strategy and the conclusion. So this slide shows the overall trend of total reported COVID case up to now. As you see, there is a sharp increase around early March, usually attributed to surge patients in Italy and Europe. So it shows the cumulative number of cases by number of days since 100 cases. So after 100 cases of each country, as you see this slide, many of the countries showed the similar trend. So this is the China, and Italy is following the trend of China, and the United States and the United Kingdom also following this trend. However, the trend of South Korea changed around 15 days after the day of 100 cases reported. As you see, the slope sharply decreased at this time. Okay, I think we did some good job controlling this outbreak at this point. We can say we did some good job at this point. And other Asian countries, such as Singapore and Hong Kong, they did also a good job in controlling this outbreak in this earlier pace. Japan showed a similar flattening curve, but recently the numbers of cases in Japan appears increasing sharply. So we need to see what will happen in 1 or 2 weeks in Japan. So this slide shows the total confirmed deaths due to COVID-19. The number of deaths sharply increased since early March. This surge of fatal cases can be explained by the fatal cases from Italy and Spain, and including United States. This slide shows the daily new confirmed deaths due to COVID-19. So this shows the similar pattern as shown in previous slide. The sharp increase in number of new deaths since around early March. So this slide shows the trend of deaths after 10th deaths. So as you see, the number of deaths increased in China in earlier phase of this outbreak. Spain and the United Kingdom and Iran and the United States are following the upsurge of fatal cases after China. The number of deaths in South Korea shows the flattening curve, and Japan shows a similar pattern at this time. So let me summarize some of epidemiology characteristics of COVID-19. We became to know the COVID virus during 3 months only. We did not know about anything about this virus 3 months ago, but we know something at this time. This epidemic started, it appears started in Wuhan, China. It spread globally. Now it's a pandemic. One of the main characteristic of this disease, this virus, is very high transmissibility. So we think this virus is spreading during asymptomatic and the subclinical phase. And clinically, based on the China data, 80% of the patients appeared self-limited without any big complications, but 15 to 20% of patients experiencing serious course, and some of them, we say 5%, goes to critical condition needing ventilation or ECMO treatment. So the case fatality rate is reported around overall 2 or 3%, which is much lower than those of SARS and MERS, but some population, those who have underlying medical condition and the elderly, the fatality rate is not low, it's high. So this slide shows the age-specific case fatality rate in China. So you see among the elderly aged 70 and 80, the case fatality rate is about 10%. And if the patient have a comorbid condition such as cardiovascular disease, diabetes, and chronic respiratory disease, they shows the high case fatality rate. So underlying disease, those who are underlying chronic disease is very high risk to this COVID-19. This slide shows the comparison of case fatality rate among countries with a high number of cases. So the CFR, case fatality rate of Italy is approaching 10%. It's really high. So it's comparable to SARS, case fatality of SARS. Yeah, and the case fatality rate of South Korea is around 1.4 now currently. So we expect this rate may increase as the outbreak goes on. This slide, current paper published in JAMA, the age-specific mortality rate among the elderly aged 70 or older is aged 88 or older is reported to be 20% in Italy. So it's 1 out of 5 died of COVID-19. So this slide shows the epidemiological epic curve of Korea. So the blue line shows the cumulative number of confirmed cases up to now in Korea. The total number is, we are approaching 10,000. Now is about 9,000 in all Korea. So the bar represents the daily new confirmed cases. So it peaked late February, reporting almost 900 confirmed cases in one day, and then the number of new cases is decreased. So currently we are reporting around 100 cases per day. So you can see the epic curve sharply increased and then is sharply decreased. So we did some response, public health response to see to cope with this patient surge. It started in mid-February. We call her 31st patient. She is a member of a religious sect Shincheonji. Since her, we observed very big spread among the religious group in southern part of Korean Peninsula. So as we observed this kind of patient surge, the Korean Public Health Authority started to test around 9,000 members of Shincheonji religious sect just after 2 days. And then after 1 week later, the Korean government declared escalated national alert level to level 4, which is the highest level of public health emergency. And then the Korean government implemented the social distancing campaign and the social distancing strategy to control this community-wide spread around early March. And then we implemented a drive-through lab center nationwide, more than 600 places to test, to do rapid test for the patient under investigation. But if we see the epidemiology curve by region, so the blue one is the Daegu Gyeongbuk area, which is the southern part of Korean Peninsula, invoking the sharp patient surge in outbreak in Korea. The curve looks down, so it looks to be controlled. But however, the metropolitan area, the red line, is Seoul, Gyeonggi, Incheon area, which has more than 20 million population, highly densely populated area, metropolitan area. The number of cases looks increasing day by day. So up to now, I talked about the overall pattern of COVID-19 globally and in Korea. Let me talk about some mode of transmission of COVID-19. It's very family oriented. We observed many cases. Once one member of family contacted, the other members are also contacted. So it's family-based transmission is very common. And then we observed the some clusters in mass gathering places, such as church and religious sector. Shincheonji is also a church-based cluster. And then we also observed some small, even though it's a small clusters, we observed many patients in densely populated workplace, such as call centers. They are working together in very small space, so the virus spread easily in such place. And then we observed many cases in the high-risk facility, such as hospitals, especially in long-term care facilities, including nursing home. The long-term care facilities are reported to be very high-risk place in Korea, as well as other countries. So in this big caution against controlling the outbreak, we need to pay attention to the infection control management for this facility, long-term care facility. But now we are observing sustained community level spread with no epidemiologic links. So even though we did some good job to contain for early detection of the cases, we expect that there are many cases which is undetected in the community. So we think they are spreading the virus beyond, outside of public health investigation. So let me talk about the public health response in Korea. We are doing we are strongly relying on containment strategy. Containment strategy is we can say two steps. We are trying to detect case as early as possible, and then we isolate them in the hospital or in other place. And then we tried massive screening and contact tracing for those who are contact history or those who are in the same church or same office. So, and then we did quarantine all of them for 2 weeks at home. So there are a huge number of population who is quarantined for 2 weeks at home. The public health center in each area did monitor those who are quarantined for 2 weeks at home. And then one of the strong characteristic or strong point in Korean public health response is testing. We did lots of testing. So this is the number of lab testing is a little bit all the numbers. Currently, we did more than 300,000 tests. So we are doing now 20,000 tests per day, and then the results are reported to the testee within 6 hours, or no later than 24 hours. So massive screening and rapid reporting, and then isolation and contact tracing is one of the way of Korean public health authorities did. So this slide shows the total tests performed by country. So we did much more tests. And then we came to find much more cases. Even though they have no symptoms or they have mild symptoms, we detected them as cases. So we can isolate them. And then we can restrict, we can control the spread of those who are mild or asymptomatic in the community. So we think we can control the spread through this kind of active containment approach. So this slide shows some drive-through testing facility in Korea. But the real challenge is now. So in this kind of pandemic, in some point, there is no way to find out there are many cases with no epidemiological links. If we don't know the epidemiological links, we cannot do contact tracing anymore. So the only way to fight this virus is the flattening the curve. So the flattening the curve means we save our time to treat, to avoid patient surge in this pandemic phase. So there may be some clinical capacity in each country. So by flattening this curve, and it do not exceed the clinical capacity of each country, we can handle the clinical problems of this virus, of this disease. But it exceeds, we have surge of, so if we see the surge of patients, the clinical, the hospital cannot cope with that kind of surge. So consequently, we see the high mortality, as shown in China, Italy, Iran, in United States at this time.
Professor Kim, we have one more speaker and more.
Okay. Yeah. So the main goal of, so we have to community mitigation strategy from now on. The main goal of community mitigation is the minimizing health hazard. So we have to prepare clinical capacity to cope with the patient surge. So we have to ventilator, ICU beds, and clinical manpower should be prepared. And then once the patient surge occurs, the clinical system can do rapid, can implement rapid triage system based on clinical severity of patient. So it means that we can allocate the patient to the hospital or in other place. So, and then we need to develop, develop the public health preparedness clinics. In Korea, many private hospitals participated in public health preparedness clinics, and the public sector centers also participating. And then we are doing some public health approach, which is the social distancing. But we are not doing the lockdown approach shown implemented in China and the US, United States. We are doing this social distancing voluntary basis and the metropolitan area focused. So we need to see what's the overall effect of less harsh lockdown on and controlling this outbreak in Korea. So this is my final slide. When we handling this epidemic, we need to think about all hazard approach. We need all hazard approach. 5 years ago, we experienced the MERS epidemic. At this time, it was in-hospital transmission was problem, but at this time, in COVID-19, it's community level spread transmission is problem. So we have to develop optimal capabilities across the scenario and better preparation for the broad spectrum of potential risks. And then, even though we are in the middle of the outbreak of COVID-19, we need to develop operational capabilities and cooperative governance between major agencies, central government, local government, and the public health authority. Cooperative governance is very important for rapid response to public health emergency. Okay, that's all. Thanks.
Okay, thank you, Professor Kim. We already have one more speaker, so please consider to the group chatting window. So already we have two questions from Dong University, Karachi, but just consider the question, and we will have a Q&A time after having next presentation. So thank you, Professor Kim. So next speaker will be Professor Jeong. She is a clinician on Division of Infectious Disease. So she is going to speak about the more clinical aspect of Corona-19 virus. Would you start, please, Jeong on Medical Research Information Center? Okay, please, Dong-Hyun Kim. Okay, thank you. Please start to. Okay, Professor Jeong, please start.
김동현 교수님 공유 좀 꺼주셔야 될 것 같습니다.
Okay, so Professor Dong-Hyun Kim, would you stop sharing your desktop? Okay, we are going to share next speakers. So, okay, thank you. Please go ahead.
Thank you for your introduction. I'm Jeong in Department of Internal Medicine. I'm taking care of the COVID-19 patients, and the Chungbuk National University Hospital have a national designated airborne infection unit. So some serious and critical patients are referred to my hospital. This slide is the same slide of another professor. This is emphasizing the rapid increase of the number of COVID-19 patients and related deaths. And I found that another professor showed that around 1,000 confirmed cases are in Pakistan, I think. And actually the number can be doubled or sometimes tripled in a few days. Actually, this virus is very contagious. And so we have some national designated airborne units, and actually we have rapidly expanded the number of AIIR to 5 to 18. So we are gathering patients in critical condition. And in Korea, patient severity are graded like this. Some patients without pneumonia are designated as mild case, and moderate, severe, and critical. I think this should be considered as a potential serious case. So mild pneumonia and high fever, and shortness of breath, and severe pneumonia, and some unstable vital sign can be progress very rapidly. So a patient with high fever and shortness of breath should be monitored very well. Sometimes, in a very short period of time, the patient can be very serious. I think, as another professor said, I think about 80% of the patients are in my case without pneumonia. Sometimes they even don't feel fever, and after repeated questioning, they just say they have just mild symptoms. Sometimes they say they have no symptom. And after the rigorous contact tracing in South Korea, just they can get a positive result without any symptom. But actually, at the same time, all the family members are infected. So I think this virus is very contagious. However, if some of them are hospitalized and we observe for about 2 weeks, about 10 to 20%, they develop pneumonia, and about 5% need some oxygen supply. Till now, we don't have any effective treatment regimen. However, we can see some report about using collateral, HIV drug, hydroxychloroquine, antimalarial drug, and steroid, remdesivir for Ebola antiviral, and pharmaceuticals is a kind of anticoagulant. These kinds of drugs are in a clinical trial in Korea, and in my center, we are using these 3 drugs. About 10 to 20% of the patients get pneumonia in later period. I found that in some patients, this progression is very rapid and unexpected. Rapid aggravation is usually with high fever. So a patient with high fever for more than 2 or 3 days should be monitored very closely. Supportive care is very important, and some critical care is very important in critically inpatients, and usually in the rapid progressing epidemical period, maybe. Usually the country don't have enough airborne infection unit and airborne ICU. So I think some designated centers should expand the airborne unit with very careful consideration. The medical personnel flow line and medical device flow line and some appropriate partition of the patient room and hospital corridor. I think oxygen therapy is very important. We can give patients the oxygen with many kinds of device, very simple nasal prong, an oxygen mask, and high flow oxygen device, and portable ventilator, and actual mechanical ventilator. Actually, this is very cheap, but these are more expensive, and we have to think about the patient condition every day. Sometimes we have to change from the oxygen delivery modality if the patient condition changes. And for medical ventilator, it's very expensive. But if the ventilator alone comes to the hospital, we cannot use it. We have to have the appropriate room for medical air supply, as well as medical oxygen. So we have to think about and count the number of the facility, the rooms for the medical ventilator. In the room without medical air, we can use portable ventilator and high flow oxygen device. This is for the room without medical air, and this can be used with the portable oxygen tank, maybe. We have to count the hospital room and prepare for the severe cases. And this is one case presentation. Actually, he was a 73 years old man and had some fatigue and fever cell and tested PCR positive 1 day after the symptoms set. And after that, he was hospitalized to another hospital, and after the 5 days, he was transferred due to high fever and shortness of breath. If this X-ray is taken in another hospital 5 days before his admission, and this is the X-ray we took on the day of admission. We found a small infiltration in left side of the chest. So he was taking collateral from another hospital. So, however, this drug could not improve his fever. So we added inhaled steroid to control his symptom, but the fever just persisted, and we added hydroxychloroquine to control his symptom, but it was not easy. After 4 days after the hospitalization, his CRP actually elevated, and I don't know the reason. The DIC profile just goes up to a very high degree, and the LDH, and in some patients CPK elevate. His CT, you could see some ground glass appearance, especially in subpleural area. And after 8 days, we could see some contracted change. Maybe this may be some manifestation of lung fibrosis, but I'm not sure. I wanted to check it in later phase, but he was not living in this area, so I could not follow this CT. So I'm sorry, I couldn't prepare many cases, but this is a typical case. Considering the viral infection is the cause, the patients have very high CRP level, and 10 to 20% of the patients develop pneumonia after 7 to 14 days. In the late pneumonia presentation, after some oxygen supply, some patients just recover. We have recovered patients on their 90s and 80s after the oxygen therapy. So, I think during the critical period, oxygen delivery is critical. And so adequate supportive care with both supportive medicine is, I think this is very critical. This is my presentation, and if you have any questions, please let me know.
Okay, so thank you, Professor Jeong, again. And already we have 2 questions from the Dow University. So before panel discussion, so would you answer the question? The question 1 is why there is so much discrepancy in case fatality rate between South Korea and Italy. Maybe this question would be answered from Professor Dong-Hyun Kim. And the second question was how did you, what are the symptoms in children and neonates? So maybe some pediatric clinicians can answer this question. So, Professor Jeong, would you answer the question from the means, or what are the symptoms in children and neonates?
I have no experience of pediatric patients, but so many reports say that children have some milder symptoms. And can you say more in another audience?
Okay, so we already have some one more clinician from Chungnam National University Hospital, Professor Youngsung Kim. If you are still connected here, please you can also answer this question. And before that answer, Professor Dong-Hyun Kim, would you answer the first question, why there is so much discrepancy in case fatality rate between South Korea and Italy? So I think that it's a very complex debate on this. On some experts already told about the age discrepancy between South Korea and Italy. So what would you answer on this?
What? South Korea and which country?
No, Italy.
Italy. Okay. I think one main reason why we have so low case fatality rate is the age distribution of confirmed case. We have many young cases since the outbreak in Shincheonji religious sect. The member of Shincheonji religious sect is our mostly young group. So we have much more young confirmed cases. So it contributed to lower the case fatality rate, since they in worldwide the case fatality of young population is reported to be low. In comparison, in Italy, the most affected population is the elderly, which shows the high mortality rate. So I think that's the main reason why we have such a big discrepancy in mortality rate, in fatality rate.
Okay, thank you, Professor Kim. So still we have one more question. If people who get infected will develop immunity, so this question, the questioner is Anelia Indus. So maybe Professor Jeong or Professor Kim can answer this one. So if people who get infected will develop immunity, please answer.
Yeah. One of the investigator found some antibody of spike protein, but we are not sure that this antibody is some neutralizing and protecting effect. They say that they can get some, and they can find some antibody in recovered patients, but until now we don't have enough data that this antibody is a neutralizing and protective antibody.
Okay, so thank you. So another question from Dr. DeHillo. So did you treat all mild case with HQ? So Professor Jeong, you can answer this one.
No. So mild case was contained in another center not hospital, so they cannot get some medication. So they are just quarantined and monitored.
Okay. Okay, so if you can focus on the Zoom group chatting window, you can also the many questions from the window. So one more question. For screening, did you use serology or PCR throat nose swabs? This is question. Question again. For screening, did you use serology or PCR throat nose swabs?
In Korea, for the screening, we use both the nasal and oral swab for upper respiratory regimen and sputum for the lower respiratory tract specimen. So if the patients don't develop sputum, we just skip the lower respiratory tract specimen. And the PCR is the main method for screening in Korea.
Okay, so another question is from Dr. Samarin Sarafaraz. Could you elaborate how napamostat helps? Napamostat, I'm very unfamiliar with this terminology. Napamostat help? Please answer. Who can answer? Professor Jeong or Professor Kim?
Yeah, this is just a further introduction. I read the mechanism of action, and they say that they had some antiviral effect of napamostat. Actually, this is for this drug is anticoagulant. I'm not sure how this acts, but right now there are some clinical trials in Korea.
Okay, thank you. And another question from Dr. Hillo. How many cases with pregnancy in South Korea? Do you think it is also high risk condition? The question was how many cases with pregnancy in South Korea? Do you think it is also high risk condition?
As far as I know, there is one report of a pregnancy woman, and I was told that she is fine. She is fine, and the baby is also fine.
Okay, so we need more study or probing the statistics on South Korean patients. So the other question from Anela Indus, any serological test in the pipeline? So I am not understand exactly what this question means, but the question was also any serological test in the pipeline? So Dr. Jeong, would you answer?
Yeah, to develop the serology test, we need some antigen, and many laboratories are isolating the virus from the clinical specimen. So after the virus isolation and protein manipulation, we can make some serologic test kit, maybe.
Okay, the other questions, role of NIV/BiPAP applications. NIV/BiPAP application. Okay, please answer.
Yeah, I think it can be helpful to patients who need oxygen.
Okay, thank you. Do you think there is a role of plasmapheresis? The role of plasmapheresis.
It is not established, but actually we don't have tried it to any patients. Maybe we can use it with some recovered plasma or something, but the data is not enough.
Okay, so question from Dr. Samaren Sarafal. So the sensitivity of antigen-based test. Do you have any data on the sensitivity of antigen-based tests? Dr. Dong-Hyun, do you answer? Can you answer? Sensitivity of antigen-based tests.
I have a big knowledge about this, but I was told that the sensitivity is around 75% or 70%. I have no idea, actually. Yeah.
Okay, we need more.
But if we can do, around 70 or 80% sensitivity is not high, so it's low. So we expect that there are many. So if we can do in a serial test 2 times or 3 times, we can increase the sensitivity. I expect, but I'm not sure whether we can do here in Korea.
Okay, I have an answer from one more clinician from Chungnam National University Hospital to the children's case. She answered, most children and neonates with COVID-19 are asymptomatic. Fever and cough are most common symptoms, but most symptomatic patients are very, very mild cases. So she suggested that social distancing is very important. School is closed, and companies recommended work at home. So citizens avoid gathering in closed space. So this, I think that this can be the answer of children's symptom and sign. And also we have another question from the Luxana Meza. What is the role of intake of hot drinks or hot water in prevention and control of COVID-19? what is the role of intake of hot drink or hot water in prevention and control of COVID-19? So who can answer this one?
I don't think it's effective in controlling the COVID-19 to drink the hot water and the hot tea. I have never heard about that. Yeah.
Okay, so I think that we need to get more evidence-based some data on hot water, the influence of hot water. Okay, another question is the role of plasma transfusion from a recovered patient to a sick one. What stage of disease is it recommended? The question is two. One is the role of plasma transfusion from a recovered patient to a sick patient. What stage of disease is it recommended? So Professor Jeong can answer this question.
Usually in infectious disease, we don't treat patients with plasma transfer because of some risk of the infection of blood-borne disease. But in this situation of the novel virus, maybe we can consider this option in very late stage, I think.
Okay, so this question would be Professor Kim can answer this question. Is it possible that you screened everyone in South Korea and Italy only cases with symptoms were screened? So would you answer this one?
No country can screen every population. So, but we did a massive screening for those who are exposed history, contact history with confirmed cases. So it is the maximum testing we can do. But in other countries, such as Italy and the United States, I know, as far as I know, they are doing tests for those who have symptoms only. And so severe symptoms only. If they have mild symptoms, they can afford the screening test for those who have mild symptoms. So the country need to prepare the test kits, much more test kits far in advance before entering patient surgery phase.
Okay, a question from Faisal Hanif. Do we need to do PCR without symptoms in person having history of confirmed case contact? So do we need to do PCR without symptoms in person having history of confirmed case contact? So who can do that? Actually, we have planned to invite some diagnostic expert, but at this time, so maybe Professor Jeong or Professor Kim, who can answer this one?
I think that is the policy. If a government decide to do some rigorous contact tracing, that can be possible. But at the time, if you test the patient, the contact case within just 2 or 3 days after the contact, even though the result is negative, the contact should be contained for 14 days. Yeah, that is the basic concept. The result of negative should not be confused as the contact is okay. So that is the basic concept, and I think this can be decided on policy base.
Okay, thank you, Professor Jeong. This question from iPhone user. What was the standard PPE that you used in HCW? What was the standard PPE that you used in HCW, Professor Jeong?
I work in airborne isolation unit, and in general words. So I will tell about the hospital policy. In Korea, in my hospital, all patients and the companion people should wear the surgical mask when they enter the hospital building. All the people have to wear a mask, and all healthcare workers wear this kind of dental mask in the hospital. But in some departments where the patients cannot wear masks, such as dentistry department or ENT, was in that setting, the healthcare personnel wear N95 mask, a respirator, and goggle to protect themselves. And healthcare workers who contact the COVID-19 patients, they have to wear at least 4 kinds of PPE, the respirator N95 and goggle and glove and long sleeve apron. But in critical setting, we use D-level PPE, and sometimes in aerosol generating procedure, we use PAPR to protect our respiratory tract.
Okay. Faisal Mahmoud questioned, quote, what testing assay were you using? Any rapid test? We are trying to scale up testing in Pakistan, but do not have enough labs who perform this. So
yeah, I think we really need some antigen-based, maybe some flu kit, the point-of-care based diagnostic. But usually the kinds of tests are not so sensitive. About 70 to 80% are just positive. But so not adequate this in the this setting. We have to find all patients. So I want to other companies to develop point of care diagnostics.
yes, so thank you. So Dr. Shuren questioned, we see transmission of infection to healthcare workers. So what is the protocol for healthcare workers to limit the spread of infection? Were they allowed to go home?
If the healthcare personnel wear the appropriate PPE, they can go home every day, I think. And I go home every day. So I think PPE is very important. Personal protective equipment.
Okay, thank you. So what is the de-isolation? What is the de-isolation plan in South Korea?
If we have, in the later stage of the patient, we perform PCR, and if we get a consecutive negative result in the PCR test performed in 24-hour interval, we de-isolate the patient. And if the patient has improved so much, but still have some positive result, then we can de-isolate the patient to their home, and the patient should be contained at home for more than 14 days. We have 2 kinds of de-isolation strategy here.
Okay, so thank you. This question is, okay, this question is Abdul Aziz Jokoyo. I am emergency department physician dealing with the sick patients. We are resource limited, very limited. ICU almost no kits for testing. Can we assume every patient with hypoxic respiratory is COVID? So, Dr. Jeong, can you answer?
Yeah, we are in resource limited setting also. We don't have enough PPE, and in order to protect the hospital and the country, we just assume that every kind of febrile patients are COVID-19. So in emergency department, the triage have to separate the patient, the possible COVID patient or the others without fever. So the possible COVID patients are treated with the healthcare personnel wearing appropriate PPE, such as goggle and respirator and vinegar gown. And we usually test the COVID-19 to the suspicious patient, all patients in the emergency department. And I think this is very important to continue the treatment without the result. After, sometimes awaiting the result, the treatment is the stop. So I think that should be avoided. We have to treat the patient with appropriate PPE and COVID-19 tests to protect the country.
Okay, question from Chicago Kannum Hospital. Can the person go into the community after 14 days of quarantine? Maybe Professor Dong-Hyun Kim can answer this one. Can the person go into the community after 14 days of quarantine?
So you mean the patient?
Yeah,
You're talking about the de-isolation of a patient after 14 days quarantine?
Yes, maybe.
Yeah, I think Dr. Jeong already answered about the question. After two consecutive negative tests of RT-PCR, he or she can de-isolated from the hospital. But we still recommend to stay at home for 2 weeks after discharge, I guess so.
Okay, so we already have behind the schedule, so I think that more questions are there. So maybe I think then we can rearrange more video conferencing at the next time. But still one or two questions. The question from Samarin Safars: what is the South Korean experience in using tocilizumab in COVID patients of ARDS? Has improvement been seen? Tocilizumab, TOCILUZIMAB. Professor Jeong, you can answer this.
I have no experience of that.
Yeah. Okay. So we need more searching on this. And what is the infectivity period of this disease? Professor Dong-Hyun Kim, can you answer this one?
I think there are many issues about that, but we currently think this virus spread infections 2 days before symptom onset. So that's the current knowledge about the infectivity of this virus. 2 days before symptom onset. So you need to contact the tracing of confirmed patients 2 days before. 2 days before symptom onset.
Okay, so one more question on children. There are children with severe pneumonia, also the reason of ARIs in children right now, whose COVID-19 PCR is negative. Should we be testing all these children and retesting if second first PCR negative? The question was that there are children with severe pneumonia whose COVID-19 PCR is negative. Should we be testing all these children or retesting if sick and first PCR negative? This is the question.
Sometimes after getting the negative result and the patient is still sick and The X-ray imaging is very typical of COVID-19. We repeat the test 2 or 3 times.
Okay, so as a coordinator of this video conference, so still we have 40 questions waiting list now. So if the clinician, as you know, clinician is very, very important at this time. So if your time is allowed, we can extend this meeting. But if you don't have time, I think that we can seek more opportunity to next video conference. So Professor Jeong, you are a clinician, so you have many patients now in your hospital. So what do you think? Can you spend more time on this or not?
Actually, Professor Lee told me that this conference will end at 4 p.m. So we have 10 more minutes.
Okay, so just so you need more working distance. Okay, so okay, we can 10 more minutes. So next question is, do you think there is any role for wearing mask in preventing community spread? So wearing mask in preventing community spread. Dr. Kim?
Yeah, this a kind of sensitive issue here in Korea, but WHO or United States CDC does not recommend to wear the mask to prevent the COVID-19 if you are still healthy. So I think that's the general principle of wearing mask, but the culture is different from the West and the East, so we need to consider about that.
Okay, so before discharge, do you check PCR and confirm negativity? So Professor Jeong can answer this one. Before discharge, do you check PCR and confirm negativity?
Yes, yes. Because I am caring for serious patients, and according to the Korean CDC guideline, I have to get 2 negative results to de-isolate the patient. If the patient improves so rapidly, and if the PCR is still positive, then in that case, we can de-isolate the patient to the house for more than 2 weeks. For all my patients, I just de-isolate after the negative conversion of PCR.
Okay, the next question was what PPE was worn by healthcare workers? So maybe they want to know the maker or brand name. What PPE was worn by HCW? Dr. Jeong, can you answer this one?
Level D PPE. That is donated by the government, so it changes, the brand changes every day. Level D PPE for the confirmed case, but so special case, we just use respirator and goggle and mask and gown. 4 kinds of PPE.
Okay, thank you. Do we screen children and pregnant ladies?
Not for the special population, just for contact tracing, we test them.
Okay, thank you. Have you found any residual damage in the lungs in people who have recovered from COVID-19? Residual damage in lung?
Yeah, but I have not performed a pulmonary function test, but in CT scan or X-ray, I could see some infiltration at the discharge point. And they are going to be followed by another hospital, so I'm not sure.
Okay, so one more question from Dr. Khalid KMU patient. This is Dr. Khalid from Kaiba Medical University, Peshawar. Professor Kim mentioned the drive-through test. Can you tell us if this was a rapid test or PCR? I think it's confusing about that. So can you tell us if this was, so drive-through test was a rapid test or PCR?
It's a RT-PCR test. Yeah, the same test as in other hospital-based laboratory. It's the same test.
Okay, so my understanding is a drive-through test means just collect the specimen, collect the sample, and then
Right. Collect the specimen and it's transported to the lab. Yeah.
Okay,
Yeah.
so lab is originally in hospital. So drive-through means just collecting the specimen. Okay, thank you.
Right. Yeah, you're right.
How soon does the PCR become positive after getting infected? How soon does the PCR become positive after getting infected? Professor Jeong, can you answer?
Yeah, I saw many patients found in contact tracing with very, very minimal symptom or even no symptom. So I think the PCR positivity occurs in the early stage.
Okay, so still we have many questions. So I think that it's time to close of this session, but some panelists from the Pakistan asked we need to check more important question than general question, but I am not expert on the COVID-19 disease, so I cannot discriminate which one is important, which one is in general, so I'm very sorry about that. So I think that, but we need more teleconference after this meeting. So I think that from Pakistan side and South Korean IT institutions, KISTI can reorganize this kind of meeting. Maybe we can hold some kind of series, COVID-19 sharing of clinical experience. So I think that so many people participated during this emergency urgently because this. I think that this is very, very productive and very, very informative to all to the participants. So I think that it's now it's time to close. So thank you for all, and especially. Okay, so someone can ask.
Hello everyone. I am Waqas Masood from Higher Education Commission, Pakistan. I want to thank my Korean colleagues from KISTI and from the Medical University of Korea, and as well I also want to thank all the doctors from Pakistan who have participated in this session. I would request all the Pakistani doctors if they can drop their contacts at my email address. So we will try to create a mailing list, and we will try to do more sessions in the future, and this way we will be able to reach out to the relevant community quite easily. Thank you everyone for your time and for your efforts.
Okay, also, and very special thanks to the center director Seo-Jin, so for your well-organized this communication. Thank you, and see you next time. Thank you. Bye-bye.
Thank you.
Be safe. So, Corona. Thank you.